Good morning. I'm astounded. This is the second day of the conference, and most of the time at this morning, early in the morning, after a couple of hours out on Bourbon Street, I would think there would be like 5 people, and so I got a few more people to talk to than I thought I was going to have. We're going to talk today about an algorithm that the Horizons International Peripheral Group has developed. We talk a lot about peripheral vascular disease, but a lot of times how you treat it, how you diagnose it, how you treat it. A lot of people, and mostly the frontline people, primary care, nurse practitioners, podiatrists, the people that see this up front, they need to be the ones that do the initial workups. They need to be the ones that recognize it. That is one of the reasons that peripheral vascular disease is so undertreated in the United States, is because of the lack of diagnosis. So we've decided in the Horizons group to develop an algorithm that you can follow by. This is just guidelines. And this is actually going to be published here in a couple of months, and so we're going to go through this here. Now, Mary Yost of the SAGE group estimated 20 million people have PVD and did an incredible amount of work. This is like was just stated, this is very important work. And because between 1 and 2.5 million people, have CLI. Now, peripheral vascular disease is a marker for death. 1-year mortality and major cardiovascular events in the 20% range. I dare say it's probably more than that, but that's what's been studied. The majority of patients with peripheral vascular disease are either asymptomatic or they describe their symptoms other than peripheral vascular disease. Classical symptoms are described. This is one of the reasons why it's probably not underdiagnosed. What people do, and as you see patients, they adjust their lifestyles to mask their symptoms. They might have been walking 2 miles a day, and then all of a sudden they're down to 1 mile a day. And then next thing you know, they're on the couch watching NFL football all the time. And the reason is that it hurts. And so instead of seeking help or recognizing it, what they do is they adjust their lifestyles. And that's one of the reasons that their symptoms or their diagnosis is not made. The other one is your symptoms. A lot of times you walk, your legs hurt, doc says, it's your back, you got a bad back. That's not always true. So that's one of the reasons they're underdiagnosed. So we started that. Now, who should be screened for peripheral vascular disease? Anybody with typical claudication, anybody with CLI, obviously, if you have a wound or a non-healing wound. Neuropathic pain, a lot of times you attribute it to diabetes, you have neuralgias, and this is not always the cause, even though we've actually shown in certain studies in people who have small vessel disease and have neuralgias that we can open those up and actually improve it. Anyone over the age of 7, anybody 50 years old who has the usual suspects, smoking, diabetes, high blood pressure, and hypertension. Now, the next question that you have to ask yourself is, what do we do? Say I screened them, they have no symptoms. Guys walking, having no problems whatsoever, or the people that are symptomatic, Rutherford 1 through 5. Or whether Rutherford 1, 2, and 3 you have to think about. 4 and 5 are much more straightforward. 3 is probably a little bit more straightforward because the symptoms are lifestyle limiting. So if you take the asymptomatic patient, and I'm sorry, I'm going to have to do this. I think it's all the computer work that we do now due to the government. I don't think it has anything to do about my age. So when you look at it, you want to screen the difference in the lifestyles. I still can't read it. You modify, you get your hemoglobin A1C down to, I like 5.5 or less. If you can get it down to 6, and most people are, quitting smoking. Smoking is probably one of the highest addictions that's out there. And control their high blood pressure and the cholesterol. Here we go. Now, the one thing you need to know here is people with peripheral vascular disease, not only do they have it in their legs, it's a total body disease. Peripheral vascular disease is a head to toe. The arteries start in the heart, which is the center, being a cardiologist, and they branch out, and they're all made of the same things. and they're all connected. People with peripheral vascular disease have up to between 60 and 70% chance of having significant coronary artery disease that may or may not be asymptomatic. So you need to screen people for that. You need to look at anyone with that needs to have stress testing. They also need to think about abdominal aortic aneurysms. Anyone over the 65 who's a smoker should have an abdominal aortic ultrasound. And if any of this is suggested, you go in and you do an evaluation. If not, anyone with peripheral vascular disease who is asymptomatic needs to be followed on about a 6 to 8 month regimen. Now, if you're symptomatic, and the symptoms can be all the way from you can walk 2 miles and start getting cramping to where I can't walk 100 feet and get cramping to the point where you have a non-healing wound in your foot. So what we decided is it's using the same algorithm. Well, I tell you what, things are just not working today. I don't have a point, but if you use the same algorithm that you do the same screening for a symptomatic patient as you do an asymptomatic patient. And then symptomatic patients will be, like I said, Rutherford 1 through 3 or Rutherford 4 or 5. They're either claudicants or they're going to have wounds that don't heal or critical limb ischemia. And so you got to take a pathway for each one of those. So if you're symptomatic and you're claudicant, you can treat them with Cilastisol, and you put them on a walking program. Put them on a reasonable walking program. Don't tell the patient, look, I want you to go out and walk 4 miles a day. No, you start out, you walk till it hurts, stop, rest, walk a little more, and mark that distance. Try to get 4 or 5 steps more, and then after a while, you'll increase your distances the more you walk. If the patient's symptoms are controlled, you just follow them about every 6 months. So what if the symptoms are not controlled and they worsen their lifestyle limiting? Then you want to go through testing. All right, and this is the same testing that you would have if you have critical limb ischemia. And then if your testing is abnormal, you want to refer them to either an interventionalist or a surgeon. And if the other part of critical limb ischemia, if you do have a wound, if you have a wound that is non-healing, you need to send them to people that can help you heal. Treatment of peripheral vascular disease is a team approach, and that cannot be said enough. It's a team approach, and it has to be whole groups of people: wound care, podiatrists, the interventionalists. You just going in there and opening up an artery is fine. It's the follow-up that is the most important thing. And then treatment of peripheral vascular disease, you have the team approach, and this is the team of people that you probably should use. And this is basically, like I said, this is just an algorithm. It is just using pathways that you can use to help treat people. And for people who make the diagnosis, and it's the people who are in the front lines who are the most important in making the diagnosis and getting these people treated early, because early treatment is the most important thing. Thank you.
So speaking of team approach, next we have the esteemed podiatrist